Hey guys, related to this topic of nurse innovation and nurse inventors and entrepreneurs, we had an opportunity to sit down with two leaders in this area, and we thought you would enjoy this content as it relates to our episode. Today I have with us Lynn Rapsilber, nurse practitioner and co-founder of the National Nurse Practitioner Entrepreneurial Network, or NPIN. That is an acronym that will not count toward our swear jar. And Sandy Berkowitz, nurse attorney, also CEO and co-founder of NPIN, which I'm going to keep using now. Well, maybe I can't, but you ladies can. Ladies, thank you so much for joining me today.
We're glad to be here.
For having us.
So why don't we start with a little bit of background about each of you. Tell our audience a bit about yourself. Sandy, I'll have you go first.
Sure. I graduated nursing school from UCSF in 1969. It was the flower power era in San Francisco, so you can imagine that I went into psych. I was told that it was psych and public health was where all the nursing leaders went. You know, that was, I don't know if that's true, but it was an autonomous practice environment. And as I think about it, and I might explain why I'm here today.
Yeah.
I went through nursing in mental health in Boston, ended up being really tired of feeling that I had to demonstrate that I had brains, you know, almost day to day. Went to law school to get sort of a union card. But before I went to law school, had been denied reimbursement by a carrier in Boston because I didn't have the right credentials to run the day hospital program. And I can hold a grudge for a really long time. You know, so at this point, Lynn and I and NPIN are working on not only autonomous practice for nurse practitioners, but getting paid for the value that they're adding. And I'll tell you how we hooked up the four co-founders after Lynn gives her story.
Sounds good. Lynn?
Thanks for having me. So my career started in the hospital setting, and I was approached by our local oncologist to do outpatient chemotherapy. And this was in the early 80s at a time when the hospital was pillar of job security. So was I crazy to leave that and go, you know, to this unknown environment? But I said, what's the worst that can happen? It doesn't work out. I go back to the hospital. So I decided to venture into oncology, and I started with the chemo drugs and had to investigate what was involved in giving them, you know, how much solution, how much labor, supplies. And then I negotiated with the insurance company. So I learned a lot about CPT and ICD. Fast forward, I went to NP training because at the time in oncology, I was at the point where I was making some nursing decisions that were probably, you know, on the fringe of my scope. And I said, you know, I should go back to school and get an NP. So I did. And during my training, they were not talking about ICD or CPT. And when I was just about ready to graduate, my professor, I had asked her, are we going to talk about CPT and ICD? And she looked at me, she goes, what's that? I go, oh boy. So I said, you know what, can I bag my capstone project and let me do an article about reimbursement? And she said, sure, let's do it. And it got published in the Nurse Practitioner Journal, May of 2000, Understanding the Reimbursement Process. And at that point, it was my passion to go educate anybody who would listen about how to get paid for what we do. And then I joined NPIN, and part of that was meeting up with one of the co-founders at an event at AANP, which is the American Association of Nurse Practitioners. They do a health policy conference every spring, and we get to go to Washington. And while I was there, CMS is always there, and I always ask Jean Moody, what's going to happen with Incident 2? Because Incident 2 billing is when you have your care billed under the physician NPI instead of yours. So the physician gets credit for all the work that you do. And they're talking about quality payment and all of this. And I'm going, well, if Incident 2 is happening, where's the NP? And Beth, our other co-founder, had overheard me, and we struck up a conversation, and the two of us have not stopped talking since. And she introduced me to Sandy and our other partner, Lorraine. I'm the outlier. I'm from Connecticut. They're all from Pennsylvania. But we all struck up a conversation and said, look, we need to, move the needle for nurse practitioners. We got to get them to feel comfortable talking about opening up practices, talking about how we get paid for what we do, helping them to negotiate contracts, all the business side that we don't get in our training.
Yeah,
We've
absolutely.
been talking about that for a long time. I think the difference is the access crisis has, plus COVID, but the access crisis has really changed the story from swimming upstream, which most of us enjoy doing, to swimming with the current and having to deal with the political forces that hold our future in their hands.
Yeah, yeah. I imagine that represents different challenges. When you're swimming upstream or against the current, you kind of get into a certain mode. You kind of know these are the challenges I should anticipate and how I'm going to deal with each of those. But then when you're like within the current, all the forces are just accelerating. That's a little different set of challenges. So for you all, or for folks that you work with, what are those differences? How are you helping people navigate?
Well, one of the things that hasn't changed is you may have the authority to practice, but nobody's telling you you're going to get paid. So I think you can always find an issue to swim upstream, I guess, to keep your imagination fertile.
Yeah.
The other thing too is we've come across a lot of nurse practitioners in particular who have been very innovative and creative in how they've been able to overcome some of those practice barriers where they might need collaboration with a physician, for example. So I think that there's workarounds that you can do to become successful. It's just you have to do that homework and find those out. And, nurse practitioners who are innovators will take that leap.
Yeah, of course. Now, we talked about NPIN, the National Nurse Practitioner Entrepreneurial Network, as being focused on autonomy and also the value that nurse practitioners in particular bring for their practice. But if you were going to introduce someone to NPIN as an organization, how would you describe it to them?
I would say
let me turn off my phone here.
Nurse practitioners who are for nurse practitioners to help them build and sustain nurse-led businesses. And we provide the support and the collegiality so that they can learn from other practitioners along the way who have maybe, made a few stumbles along the way. And some of these stumbles can be pretty costly. And when you're talking about an NP starting a practice, our margins are very slim. So you really want to make sure you're going to maximize, the opportunity that you have before you. So we learned from a lot of our predecessors some of the pitfalls, and we want to try to help prevent those from happening because a lot of these NPs that open up practices did it in isolation. There wasn't a lot of information out there. There's no support. And we recognize that. And we recognize that our national organization is great at, keeping us clinically astute and health policy related and research related. But when it comes to the business side, we really needed to have a lot more support in that area.
Yeah, absolutely. And I think that is a world of difference, nurse practitioners supporting other nurse practitioners or nurses to understand a little bit more about where they're coming from and some of the unique challenges that we have, certainly. Now,
and I can understand from an academic perspective too, that, there's only so much you can put into, your semesters to get the nurse practitioners educated and trained. But I know doing my coding and reimbursement lectures, it started out really slow, but now, I do a lot of lecturing for colleges just to give them some perspective on what it means to start thinking about their value within a practice and what to look for and how to, quantify that. So it's really important.
I would agree. If it makes you feel any better, I've gotten for years requests from students for more billing and coding content and practice. So our students certainly want it. It's hard to find nurses and nurse practitioners who know it well, who do it every day, who make it kind of their own professional development area though. So I'm glad that you're offering that for the folks in your area.
Oh, I travel all over the country, so.
Wonderful. We should talk.
Yeah.
Now, so we've talked a little bit about sort of nurse practitioners starting practices, and I'm curious how many of those are sort of your traditional nurse managed clinic models, and if you're getting any requests from people who are doing some more creative ways to deliver care.
Well, I think one of the things that we found, we had a booth at AANP at a conference, and just standing there and listening to some of these great ideas these NPs had, it was just phenomenal. I remember one story of the nurse practitioner who was doing something. She was a pediatric NP, and she was very interested in psych mental health, but she had this DMP project, and I even forgot what that was. But what drew me to what she was talking about was she wanted to go to the daycares and to do therapy with the kids at the daycares. And I said, how innovative is that? Nobody's doing it. And I said, you should develop a business about that. And that should be your DMP project so you can build this business. But unfortunately, there's not a lot of support to find somebody that could mentor somebody in that type of situation. But I'm wondering if she took that leap and decided to do that. But we've heard some stories of, great ideas that nurse practitioners have. It's just they have to start to operationalize them.
Now, I also know that in the practice of nursing, we have sort of the culture of being, so I'll say servant-hearted, which is not separate from being business-minded. That's okay. But sometimes that takes us in the direction with our colleagues in particular, where not only are we not being business-minded, it's seen as not as truly nursing, truly serving people if you also plan to conduct a business and get paid for the work that you're doing. I don't know how often you personally have experienced that, or if some of the members are talking to you about that in the network.
One of the first mantras that, I used in talking to my co-founders was no margin, no mission. And Beth, who happened upon Lynn, looked at me and said, NPs will never understand what that means. You need to explain that. That's shocking. The quote comes from the head of the Daughters of Charity system, the CEO, who was a nun, who was interviewed by the Wall Street Journal about the Bermuda domiciled captive insurance company that the hospital system owned. And, how could you be sending your money offshore? And, that's so unpatriotic. And Sister Irene looked at him and said, no margin, no mission. And I've always remembered how courageous that was.
Mm-hmm. Yeah, absolutely. Especially given that situation. I did not know that's where that quote originated.
Yeah.
How about that?
Sister Irene Krause.
And I know one thing else that we're hearing from our colleagues, and why a lot of them are drawn to coming to hear, what we have to say, is that they're frustrated with the medical model delivery of care. It doesn't fit our nursing model of care delivery. And, the fact that we have to see so many patients in an hour and productivity, that kind of flies in the face of how we were educated as to caring for patients. So our hope is that nurse practitioners, the more we develop our practices, the more we're, innovators in healthcare, that we can kind of shift that focus so that people will understand that the value is in keeping patients well, and who better to do that than nurses?
Absolutely.
I remember when patient-centered medical homes it became the rage. Mm-hmm. And we sort of looked at each other and going, isn't it nursing? So that's sort of a perfect example of not recognizing the value of the nursing process, and then being sort of stymied in terms of the scalability of it.
Yeah.
Yeah,
that patient-centered medical home is a near and dear sensitive spot for me. So my practice is a PCMH. It's been recognized since we opened. And I read the book by the originators on the medical home model, and how frustrated they were with practice, and they wanted to come up with this sort of playbook. And of course, the nomenclature is a problem for a variety of reasons. Like a medical home, remember people are like, well, there's a nursing home. Now what's the medical home? Is that like a place? Like, no, it's a concept. And then the fact that it's medical home instead of like a team-based model. And then of course, the first principle in the true PCMH is that patients have a dedicated physician. They're very specific about that. Now, I think there are a lot of really good things about that concept, obviously, since I've got a practice that's, modeled in that way. But now I see some better approaches, either the VA's version of the patient-aligned care team, or just conceptually advanced primary care models. So this is sort of primary care plus, which I think is a much better way to come at it. That was a challenging time. I have to tell you, as a nurse-led practice, that was a medical home designated place. But I think there's so many nurses who looked around and said, this is our playbook. What's happening?
I think appreciating that our goal is not cure, it's achieving the highest level of wellness, is such a transferable concept. That explains so much about when you're arguing about value-based purchasing. The idea that, let's see, I just lost my train of thought. It'll come back to me.
I was going to give you a minute.
Thanks. That's all right.
Alrighty. Well, so one thing I wondered about is, nurses have been innovating. We've been having our own practices as much as we can, with obviously those inherent challenges. We talked a little bit about swimming with the current right now, and we sort of were talking a bit about what's been happening in this year, but in particular around COVID-19 and all of the challenges that people have faced accessing healthcare. I'm curious how that's influenced members in NPIN or folks in your network who are trying to innovate different ways to get around some of the challenges faced by just being in physically closed spaces, and if you're seeing new innovation that looks different this year because of COVID.
Well, I think one area COVID has kind of catapulted forward is the whole concept of telehealth, and that you don't have to physically be in the same room with the patient to do a great assessment and give them great care. And nurses have been doing that right along. We've been in home-based care for a while, but a lot of nurse practitioners are doing home-based primary care, house call practices, direct primary care. There's lots of ways that you can develop a practice without brick and mortar. So telehealth, I think, has really allowed the opportunity for that to happen, not to mention all the barriers to our practices being, melted away right now while we're under this pandemic. So we really have an opportunity to take advantage of some of this right now and really show what we can do as NPs to provide that care for patients. And they're loving it.
Yes. Yeah, I think that's one of the best pieces is when patients are really driving the way that they get to access care.
I think really the waiver of scope constraints in states that are in jurisdictions that are not currently full practice authority states
right here
makes it right here.
That's right.
Makes the sort of genie is out of the bottle, in terms of access, but also demonstrations of safety. The argument has been that nurse practitioners are not safe as autonomous providers. Mm-hmm. And, you can look at 25 states and sort of draw that clear view that that's wrong, although legislators seem to buy into it a lot. Mm-hmm. But the idea that there is, Massachusetts is a good example, that they had sort of waived practice constraints, and now they're measuring the outcomes. So it'll be and the cost effectiveness of the outcomes. I think that'll be much harder for physicians and others who are set in this is always the way we've done it, can argue. But the other piece that has changed with COVID is that fee-for-service payments have always been viewed as the safe payments.
Mm-hmm.
You know, they're budgetable, they're certain, you can predict them. You know, we've definitely heard NPs say that, you know, capitation or anything that is not strictly fee-for-service is unethical, if not illegal. You know, that's not true. But the idea that if you were on a payment model that paid you month in, month out based on your patient panel rather than the number of procedures you've done, you did a whole lot better than the fee-for-service counterpart. And that sort of was almost an aha moment for practitioners who have totally resisted this idea of alternative payment models. You know, well, you mean they aren't seeing any patients, but they're still getting paid? You know, so that's an aha moment. But then the other part of it, you know, is connecting we have better outcomes, we have lower costs, and we can count on that continuing because we're hardwired, you know, to be holistic. And so we're going to do better under risk-based models than we do under fee-for-service. And we're sort of hoping that that's a vein to be mined.
Hopefully so. Absolutely. So I want to ask you all just one more thing, and that is for that nurse practitioner looking at this mess of configuration that for their patient population or for them as a healthcare worker, it's just not working, and they have an idea for something that would be more effective that they want to put in place. Where do they start? Lynn, I'll start with you.
Well, I think they have to look at their idea and see if anything else is out there and see what their competition is. And then if they are kind of innovative, what they need to do is talk to somebody like our group that can sit down and look at their idea and help them formulate their next option. We talk a lot about developing their business plan and helping them through that process. We have a lot of mentors that are out there now that can actually be supportive of some of these newer practitioners coming through. And we're hoping that that is really how we're going to sustain the next generation of NP business owners, is by learning from all those who have preceded them.
I'm not surprised that you said NPIN. But I also want to give a lot of credit to the small business development centers that are located in every state. The one in Connecticut has been extremely helpful to us as a startup, you know, and helping us focus on that maybe our mission is shifting from connecting nurse practitioners to each other to helping accelerate the transition of a nurse practitioner into being an owner. You know, that's sort of a different customer.
Yeah.
And we didn't pay anything for the work they did with us. And we walked out of there going, we are buzzed. You know, this is, I mean, truly. So.
Yeah, it's
Better than our peach wine.
Right. No, it's a great idea. And I think the small business development centers, again, it's not something I think in our focus area. It's sort of outside of healthcare, outside of what we've been educated to think of or to know about. So that's great information for folks who are interested.
Yeah. And we have to look at other stakeholders, because it's not just about us. It's about, you know, who else we can bring to the table or whose table we can sit at to help make some of those changes too.
Yeah, absolutely. In particular, I'm a big fan of patient advocates in those conversations. Yeah.
Absolutely.
Well, ladies, I can't thank you enough for taking the time to talk with us, to bring this information to the audience of the Nurses Station show. This is kind of a different Nurses Station to be chatting around, but we're glad that you were with us. And again, I just can't thank you enough.